Sir, we can start. We are live.
Good evening, everyone. Welcome to the Journal Club for this month. Today we have Dr. Priyanka from AIG Hospital. She is the DRNB resident, and her guide, Dr. Shiv Kumar sir, senior consultant from AIG Hospitals. I welcome Dr. Jose Chaco sir, Srinivas sir, and Gansham sir for this Journal Club. Today we'll be discussing on the effect of high versus standard protein provision on functional recovery in people with critical illness. Over to you, Dr. Priyanka.
Good evening, everyone. This is Dr. Priyanka. Thank you for giving me this opportunity. I hope you all had a pleasant day. Let's start this evening with the PRECISE trial. So the trial actually wants to show the effect of high versus standard protein provision on functional recovery of patients, of critically ill patients. So basically, all those patients who have survived in our ICUs all often have a low quality of life. This reduced quality of life has been attributed to the persistent muscle wasting and weakness, among other factors, which developed during the first week of ICU admission. So increased protein provision might ameliorate muscle wasting and improve long-term outcomes in the critical illness. However, evidence is controversial as observational data show both benefit and harm. So guidelines from the European Society for Clinical Nutrition and Metabolism recommended enteral feeding over parenteral feeding and daily protein intake of 1.3 gram per kg, whereas guidelines from American Society for Parenteral and Enteral Nutrition recommend daily protein intake ranging from 1.2 gram per kg to 2 gram per kg. So what are the previous trials? There was a similar trial which wanted to compare high protein to standard protein dose. It was EFFORT trial, which was published in 2023, which took all the adults within 96 hours of ICU admissions who were expected to remain mechanically ventilated for at least 48 hours with at least one nutric risk factor. So the final conclusion of the study was the time to discharge alive from hospital in the high protein delivered group was did not improve with the high protein. It did not improve the time to discharge alive, and it might have also worsened outcomes in patients with AKI and severe and greater severity of illness. So coming back to the PRECISE trial, so what is the clinical question? It's to assess whether the higher enteral protein provision, that is 2 gram per kg per day, would it improve the health-related quality of life, unlike the EFFORT trial, which took into account the number of days of being alive. So now we are actually taking into account the health-related quality of life and functional outcomes in critically ill patients who were actually mechanically ventilated, comparing it to the standard enteral protein provision, that is 1.3 gram per kg per day. The study was investigator-initiated, double-blinded, multi-center, parallel group, RCT, in 5 Dutch hospitals and 5 Belgium hospitals. It was conducted between November 2020 and April 2023, included 935 patients, and they were randomly assigned. The protocol was approved by Independent Medical Ethics Committee of Maastricht University and also University Hospital, Brussels. The sponsor did not have any role in study design or data collection or data analysis or interpretation or writing of report. They just advocated to use the EQ-5D-5L health utility score. The population that were included were who were initiated on invasive mechanical ventilation within 24 hours of ICU admission, and they were expected the expected duration of invasive ventilation was 3 days or longer. They excluded the patients who have contraindications for enteral feeding and moribund condition, BMI less than 18, kidney failure with no dialysis score, and hepatic encephalopathy. So the consents were taken. The deferred consent was taken at Belgium site or at Dutch sites, and at Belgium sites, they were informed by the proxies were informed about the study. So the intervention was Patient received isocaloric, both intervention and control groups received isocaloric enteral feeds with a higher protein in the intervention group, that is 2 gram per kg per day. In the control group, 1.3 gram per kg per day. The protein targets were prioritized here than energy targets. To increase the nutritional adequacy, routine assessment of gastric residual volumes was avoided, and use of prokinetic drugs were used at the discretion of treating physician. And to avoid the potential risk, supplemental parenteral nutrition was avoided during the first 7 days of ICU admission. The sample size was calculated to get a mean difference of 0.06 of EQ-5D-5L value, EQ value, to get a power of 80%, with excluding the attrition of 5% with alpha value of 0.05. Sample size was initially calculated to 824. But during the first interim analysis, after 50% of the plasma inclusions were done, the actual mortality was higher than anticipated. So Monte Carlo simulation was done, and in which 935 were required to obtain the sufficient power. So the new sample size was fixed at 935. Patients were randomized, assigned to one of the 4 randomized labels corresponding to the 2 groups, the standard or high protein, and the 2 with 1:1:1 ratio through an interactive web response system. The randomization was done via random permuted block randomization. The blinding was also perfect, like blinded study feeds were supplied by Nutricia in identical 500 ml containers with a study label. Previous studies have also shown the feasibility of this approach to maintain the double blinding. The 2 labels per study approach were to minimize the risk of full unblinding. Participants, care providers, investigators, outcome assessors, data analysts, and the independent data safety monitoring board were all blinded to group allocation. And also unblinding was also done in a stepwise manner. So finally, the outcomes that we are trying to study here are, the primary outcome was the quality of life, the EuroQol 5-dimension 5-level health utility score at 30, 90, and 180 days after randomization, which was adjusted to the baseline EQ-5D-5L health utility score. So it was this EQ-5D-5L, it can be a descriptive system or a visual analog system, EQ-VAS. Here we are using a I'll just explain it in a while. The EQ-5D-5L, so it takes into account 5 dimensions, that is mobility, self-care, usual activities, pain, discomfort, anxiety, depression. And each dimension is assessed at 5 levels. So when the upper one is the descriptive system, and the lower one is the visual analog system. So whenever a patient ticks a box in the descriptive system, that becomes his health state. You shouldn't add those numbers. That becomes his health state, and that is referred into a value set of book that is specific to a specific country. And for that health state, you will get an index value, and that you will have to see on the 0 to 1 scale. The negative is also there. 0 is being dead, and worse than being dead is also taken as a negative value, and full health is taken as 1. And you will have a index value of that health state for that person. So higher EQ 5D-5L health utility score indicate better health-related quality of life. Baseline reflecting the health-related quality of life before the onset of critical illness was obtained from a proxy upon provision of the informed consent. Baseline proxy completed is an accurate estimate of the self-completed EQ-5D-5L. So this is the primary outcome. What are the secondary outcomes? The longitudinally measured functional outcomes as the SF-36, which includes the physical health score and the mental health score. Physical health score has 4 domains, and the mental health score has 4 domains. And each domain has, again, 2 to 4 separate items in it. They've considered this in the secondary outcome. SF36, MRC sum score. This is Medical Research Council sum score, which takes movement at the shoulder, elbow, and wrist joint, and hip, knee, and ankle joint. And each movement has 0 to 5 scoring system. They've also considered Rockwood clinical frailty scale, which includes 1 to 9, from very fit to terminally ill. So, those were the secondary outcomes. Coming to the baseline characteristics, they included equal numbers. They took equal percentage of patients according to the age, sex, BMI, maybe with the admission diagnosis, comorbidities, Apache scores, SOFA scores, comorbidity indexes, and also clinical frailty scales. So, coming to the trial profile, initially 4,306 patients were eligible, of which 1,116 were eligible but could not be randomly assigned, and 2,000 patients were also excluded. Finally, as we've discussed prior, 935 patients were taken and they were randomly assigned. Of them, 465 were allocated to the standard protein provision and 470 to the high protein provision. Of the 470, 9 could not receive the allocated intervention, 3 withdraw, 2 were resumpted to the full oral intake, and 2, because of the medical decision, they were not given, and 2 died. And 51 lost the follow-up for the primary outcome. Maybe it be patient withdrew from the consent, or the proxy withdrew from the consent, or the survival they survived, but they could not be contacted. Even though even though 9 did not receive the allocated intervention, 51 lost the follow-up, we analyzed all the 470. This is the intention to treat analysis. In the standard protein provision, 465 were allotted, of which 2 did not receive allocated intervention, 35 lost follow-up, but 465 were analyzed. Coming to the primary and secondary outcomes. So the primary outcome, the EQ-5D-5L, the high protein group had a lower EQ-5D-5L, which means it's a detrimental effect. And the p-value, though it was statistically significant, but we were actually looking for that 0.06 difference between the comparing groups. At 30 days, it had the difference, with high protein having a deleterious effect, but at 90 and 180 days, it did not have that 0.06 change. The secondary outcomes, as we've seen, SF36, the physical component, the mental component, they did not have any significant p-value. Also, the percentage of predicted 6-minute walking distance, the MRC sum score, the hand grip strength, and visual analog score, none of them had none of them have a significant p-value, except for that of percentage of predicted 6-minute walking distance. But there was a missing data for that particular parameter. Even Rockwood clinical frailty scale did not show any significant difference between the standard versus high protein groups. Adverse effects were also seen. The overall mortality in the high protein group was more than the standard protein group, and also the other adverse effects of infections, AKI, refeeding, those were also considered. So coming to the discussion, the mechanism underlying the deleterious effects of this higher enteral protein doses is unknown. The increased amino acid supply might have surpassed the capacity of the protein synthesis, leading to the increased amino acid oxidation, which can have this potential toxic deamination products. Additionally, exogenous proteins in the acute phase of critical illness might delay recovery by surpassing the autophagy. The observed sex difference in the subgroup analysis is intriguing, but hypothesis generated and requires substantiation in the future research. An explanation of this would be the high enteral protein provision and sex could be relatively lower lean body mass in the women, leading to the higher protein delivery relative to muscle mass when protein is dosed per total body mass. So analysis showed that the negative effects of high protein were prominent in the medical than in surgical patients. It may be because of the protein demands are higher in the post-operative patients to facilitate wound healing. The strengths of the study are, it is double-blinded, high achievement of enteral protein targets, which enhance the internal validity, the use of patient-reported primary outcome that incorporated mortality as a competing risk. The limitations of this study are the difference that was chosen as a clinically importance, that is 0.06, it could not be achieved. However, there are no consensus of this value, and the difference ranging from 0.04 to 0.07 were also considered relevant. The dose of study feed was not adjusted for non-nutritional calories as propofol and all, as it would affect the protein dose, but the target trial reported no detrimental effect of this protein provision exceeding 30 kilocalories per kg per ideal body weight. So not very significant. Although the longitudinal assessment during the 6 months of patient-reported and functional outcomes is considered a strength of this trial. There was relatively high amount of missing data. The missing data was also more with the physical test requiring in-person follow-up. Highest amount was observed in the 6-minute walking test, demanding the physical test, making it prone to bias. The missing data, though there was a missing data, the missing data was no inherence to assessing the primary outcome, for the missingness can be was considered to be missing at random. So generalized linear mixed effect model assumes data are missing at random and therefore will produce unbiased estimates. For that reason, sensitivity analysis was conducted in which covariants likely contributing to missing at random mechanism were added as a fixed effects. The conclusion is further research is needed to clarify protein needs during different stages of critical illness, as in from day 1 to day 2, it's acute early phase, which full nutrition can cause risk of overfeeding. 3 to 7 days, the acute late phase, where it's the transitional phase where the recovery begins and the requirements are ramped up. Whereas after 7 days, it's a chronic late phase or anabolic phase, where your regeneration of muscle starts and you have to give full nutrition. So the further research is aimed to clarify protein requirements at these different subgroups and different phases of critical illness. The study result warrants further research on sex differences in the response to protein provision in critically ill people. To conclude, caution is warranted when dosing nutritional protein in critically ill patients. So this is a PRECISE trial. Thank you.
Thank you, Dr. Priyanka. I would like to ask Dr. Shiva sir about this current practice and his take on this trial.
Yeah, thank you, Dr. Navina. Thank you, Dr. Priyanka. That was an elaborate presentation of the PRECISE trial. And before I actually tell my personal how I use proteins in the nutrition, so I would like to tell that this is a very much needed question or a needed concept, because to achieve the concept of personalized nutrition in a patient, we need to know the exact target for a patient. What is the exact number of calories? What is the exact number of proteins? So in that direction, we need a specific idea as to how much of proteins is required. Unfortunately, none of the studies were able to prove it. And recently, the EFFORT study tried to address these issues, but it had a lot of drawbacks, such as it was an underpowered study. It had, it was not a blinded study. And also, it did not have any functional analysis scores. It just said, okay, mortality and time to discharge. So that were the drawbacks which were addressed in this particular study, wherein they addressed everything. It was a blinded study, functional analysis was there, and everything were addressed, and they made a robust study. And they were able to even see minute details, such as like even how much amount of propofol has been administered, and all these things were evaluated, taken into consideration. And their conclusion, they came to a conclusion that it was almost similar to the effort trial. But when we evaluated this particular study again in detail, what we found is probably can we implement the functional analysis practically? I'm not very sure, because the thing is, the first time when the patient comes and the patient is included in the trial, it is that time the first analysis is done by a proxy. We don't know whether the proxy has stayed with the patient. We don't know whether the proxy is giving the correct details. And also, the thing is, when we are doing this particular analysis, what happens to the when the patient himself analyzes, we don't know whether he's doing it in a correct way, because it's all subjective. So there can be a significant variation across patients. And also, the major other flaw is with this, they are telling that this functional analysis is different across different countries. So how did they come to this particular data sets? So I had actually evaluated and I just went back and then searched, was there any data set for India? Yes, there was a data set which was validated in 2019, but that included only 4,000 patients. And then that had somewhere around, 5 states of India were included. That's all. So is that a representative sample of somebody, which we are considering for the whole of India? I'm not sure. Then the other thing is, this is not able to use all the subgroups. Like, for example, they have divided the surgical patients, but then there are patients who are having trauma, who might require higher protein requirement, higher catabolic requirement. That has not been addressed. Or also somebody like burns patients, whom we might have to give a higher protein in them. And then they have also, in their analysis, they have weirdly excluded something such as the supplemental parenteral nutrition after 7 days, addition of supplemental nutrition after 7 days. Wouldn't it cause harm to the patients? I'm not sure whether the supplemental parenteral nutrition has been initiated later on. Then the other things what they have done is they had this issue where they had a higher mortality in between. When they did this interim analysis after doing 700 patients, they realize that probably the mortality is high and they have to do some sort of an arrangement to adjust the power. So there again, they have done a Monte Carlo situation, but I don't know whether that reflects a better, it reflects a correct analysis. So that's one more thing. And then the other take which I have is, our conventional wisdom is always that somebody who is having a higher proteins might be at risk of AKI. Even the last study, the effort study, also suggested similar thing. They had a higher mortality in patients who were having AKI and received high protein. So all that probably was not addressed. Here, I think both the groups had same outcomes. But again, that's a question mark, because our conventional wisdom always says that probably high protein can cause some amount of acute kidney injury. Then this data about the missing data and all. So all these things probably make me question this, the results of this particular study. But I think the forum is open for discussion. I think.
Thank you, sir. Joseph, your take on this trial?
Yes, Navina. So they compared the conventional protein administration of 1.3 grams per kilogram per day versus 2 grams per kilogram per day across a heterogeneous group of patients who are on ventilation for more than 3 days. So as we heard, across the board, for all comers who are ventilated for more than 3 days, it may not make a difference, but there may still be subgroups of patients, like, for instance, patients who are nutritionally debilitated at baseline, patients who have a longer-term illness, patients with muscle wasting. These may be specific circumstances in which a high-protein diet may be appropriate. But this study did not address a specific subgroup of patients. It was just across the board for all patients who are ventilated for 3 days or longer in a medical intensive care, excluding surgical patients, of course. So based on this study, the convention would be, the take-home message would be, extra protein of more than 1.2 grams per kilogram per day, 1.3 grams per kilogram per day, is not going to help across the broad subgroup of patients. There are, of course, a few limitations associated with this study, which include the fact that there was quite a significant loss to follow-up, 7.5% and 10.9% in those two groups, which is a substantial number. And in a study in which you expect a close outcome, this may matter in the end. There was missing data, which obviously could have made a difference too, particularly in regard to the 6-minute walk test. So overall, this study reflects whatever the effort study also showed, but it scores higher than the effort study by the Canadian group, Highland et al. The effort study looked at mortality, 60-day mortality, as one of the outcomes, which mortality may not be a good outcome to look at with the nutritional interventions like higher protein dose. So these authors, they looked at a much more pragmatic and much more relevant outcome as in the functional score, although the methodology by which they assess the functional score, as we heard, may be open to question. But I do believe that a functional outcome analysis may be better than, say, for instance, mortality or ICU stay or duration of ventilation, particularly in regard to an intervention such as high versus low protein. So based on this study, our practice is not going to change. We have not used a high protein diet among our patients, regardless of the duration of ventilation. We go by 1 to 1.2 grams per kilogram per day. We will stick to that level for the time being. There may be exceptional situations in which clinical judgment suggests that perhaps a high protein level may be helpful, especially in those who are nutritionally depleted, in whom we expect a long duration of weaning, particularly with neurological disorders, say Guillain-Barré syndrome, or any other kind of neuropathy in which muscle wasting is prominent. Under such circumstances, perhaps you would still consider, but overall, our practice will not change based on the findings of this study.
Okay, sir. So would you still continue to give 1 to 1.5 or 1.3 milligram per kg per day, grams per kg per day?
Yes, that's our strategy has been that for the last several years, several decades, I would say, and it would largely remain unchanged based on these two studies, the effort trial as well as the PRECISE trial that we have now.
Thank you, sir. Srinivasa, your take on this trial?
I think it has been summarized both by Siva and Joseph. See, I think the whole paradigm of providing proteins exogenously to match the catabolic state of critical illness is undergoing a change. And as we understand this more and more, reversal of the pathophysiological process is probably the only step which will result in an anabolic phase restart. So anabolic nutrition, is it really possible, is a question which is being asked in nutrition circles. That's the first point. Second point is there are some experimental and research oriented methods by which you can estimate the protein loss of a critically ill patient when he's not on extracorporeal circuits. Now, these patients in ICU who are highly catabolic are more often on extracorporeal circuits than they are not. How much of protein is lost in the extracorporeal circuits or filtered in the extracorporeal circuits, nobody has quantified. So you can never catch up with the protein loss by giving iatrogenic supplements. We have realized that although surgeons won't accept, they still give albumin to increase the serum albumin. Other specialists as well. The same logic is probably, we used to say that the only way you can correct somebody's albumin is by giving enteral protein. Now that paradigm also we need to rethink. Just as less is more in critical care, there are several situations where less is more. This is again one of those where too much of protein can actually be counterproductive to the overall recovery of the process of critical illness. So I think this study re-emphasizes the point that do it in moderation, but don't overdo your protein supplementation among critical illness.
Do you think giving a higher protein, like in the higher standards, in patients who didn't have a AKI background, will lead to AKI?
It could put protein load on the system. And so it depends upon the intrinsic renal reserve of the patient and what is the renal perfusion pressure and index of the patient. So it's not that every patient responds the same way with the renal reserve. So it could actually be putting unnecessary protein load on an already stressed kidney. It's something we need to think about.
So even in those patients who don't have a background AKI can lead to a AKI with a higher protein intake.
It is possible.
Ghanshyam sir, your practice?
A few points, Navina. I think our understanding about nutrition in critically ill patients, has kind of evolved in the last few years. Now, with respect to this trial, right? They were able to achieve 100% calorie by day 4, right? In both the groups. Am I right, Priyanka?
Yes, sir.
Right. Now, that is something that you don't want to do, given the understanding that the delivery of macronutrients, be it the calories in general or the proteins in general. When you give full dose of either calories or proteins within the first 3 to 4 days, we know that the outcomes are bad because they have a lot of negative effects. It inhibits your autophagy, it inhibits your cellular repair mechanisms like ketogenesis. It is during a period when there is anabolic resistance. So one thing is little surprised that they were targeting 100% of calories within the first 4 days. Now, even if you look at both the ESPEN and the ASPEN guidelines, they both don't recommend. Hello?
1 mark to Fireno.
Priority 1 mark to.
ఇవ్వట్లేదా ఎందుకు
Practical in this 47.
Srinivas, can you please?
100.
Srinivas,
కావాలని.
చేరి నిమిషం
hello?
Go on, sir.
Yeah. So even if you look at both the ESPEN and the ASPEN guidelines, none of the guidelines actually recommend reaching your target calories within the first 4 days. ASPEN says reach it over 7 to 10 days, and ESPEN says you reach it after the first 72 hours. That to 70 to 100%. So achieving 100% calories within the first 4 days was something which probably should not have been done because that has been shown to have negative effects. That is one thing. Second thing is, with respect to the dose of protein, I think the way we are going to feed our patients is just like any other patient. For example, say if you have a patient with septic shock and hypotension, right? You are going to titrate your fluids, you're going to titrate your vasopressors, right? You keep on increasing or decreasing the dose of vasopressors based upon your target blood pressures and the organ perfusion. Similarly, with respect to critical ill patients and nutrition, I think we need to look at the timing and titrate our dose. For example, with respect to proteins, what we normally do is we start at 0.8 to 1 gram in the first 24 to 48 hours or up to 72 hours, then gradually build it to 1.2 to 1.3. But once the catabolic phase is over and once the patient is transitioning, now clinically it's very, very difficult to identify when this shift happens. But in general, if your systemic inflammatory response has come down, if you have inflammatory markers like your CRP, etc., those have come down, your metabolic parameters are settling down. That is typically happens when the patient is recovering from your illness. You're getting them off the ventilator. You find that there is spontaneous mobilization of the fluid which has been accumulated. The patient goes into a diuretic phase. Now that is probably the time phase when the patient is going into an anabolic phase. So that's the time period where I think you have a definitive role of giving a higher protein, maybe going up to 1.5 to 1.7 or up to also 2 grams, especially when you transition the patients from outside the ICU to the wards or to home. The third thing is, see, whenever we are looking at functional outcomes or functional recovery, now proteins and nutrition is definitely one aspect, but the other major aspect which influences your functional recovery is what kind of a rehabilitation program each patient has gone through. So again, there is a amount of data to suggest that your protein would be much better if you combine a good quality of protein, a good dose of protein with resistance training. I don't think there has been any mention about what kind of a rehabilitation program was given to these patients. So that also has a significant influence. For example, if you have those patients in the control group where, or the high protein group where a proper rehabilitation program was not there, then even if you deliver a higher protein at this point of time, probably that may not translate into better.
I think we are losing your signal, sir.
It's broken off, I think.
Yeah, I think he's driving, so we may
Yes,
not catch him.
he's driving.
Yeah.
Okay, so we'll come back to you, Joseph. What do you think is the ideal kind of dosing of protein in different stages of a patient who's admitted to the ICU? Right after admission, while he's recovering and he's weaned off the ventilator, and one he's just out of the ICU.
Yes. So, as Kanshya mentioned, early during the clinical illness, early during the ICU phase, you need not aim for full 100% nutrition in terms of calorie intake or protein intake. It can be a gradual step-up process. And particularly, trophic feeds versus full feeds have been compared, and trophic feeds in the early phase have been shown to be as effective as full enteral feeds. So we need not rush into giving a full protein component right from the beginning. And of course, most of the time you start slowly anyway. You would start feeding preferably within the first 24, 48 hours in all ventilated patients, provided their gut is functional and there are no obvious contraindications. And you build it up over time. These authors, they reached 100% within 4 days, stepping up by 25% per day. So that is one approach, of course, but even a slower build-up may be okay. So I would not particularly worry about 100% target by, say, day 3 or day 4. Even if I lag behind a little bit on that, I believe it wouldn't matter. And it also depends on the whole course of illness. If I'm right, these investigators, they continued their strategy for a period of 9 days or so, 8 to 9 days or so. So for longer term patients who require a longer duration of weaning, a high dose may matter, a higher dose of protein may matter. It may not matter so much in the short term. That, of course, is purely conjecture. It has not been studied. And perhaps it is an opportunity to follow up from this study to look at specific subgroups of patients who may be at risk of nutritional depletion and who might fare better. And yes, the level of rehabilitation also matters. These investigators in the PRECISE study have not particularly specified, but we assume that patients in both groups got similar levels of rehabilitation. So all this put together, as a general rule, as I mentioned previously, I wouldn't use more than 1 to 1.2 grams per kilogram as a maximal protein dose across the board in almost most of my patients who are on ventilation for more than 3 to 4 days.
Thank you, sir. So like we discussed about mortality not being used as the primary outcome, the better outcomes will be the functional outcomes. The effort trial actually used discharge alive from the ICU. So what
Yes.
other outcomes would be better outcomes comparatively? to look at as a primary outcome, not as secondary
Yeah,
for this kind of a trial?
level of physical tolerance would be an important factor. It should not be too subjective. Subjective opinion about themselves may vary, as we heard before. So some kind of objective physical assessment by an assessor according to a set protocol would what you would aim to do under ideal circumstances. Of course, the mental well-being also matters in terms of anxiety, depression, and so on, which was all included in the UCOL scale that they use. It cannot be perfect. It is not easy to do a functional outcome close to perfection. You can only achieve as much. It's not easy either to follow patients in the long term, ranging for up to 6 months, and to do a proper physical examination, person-to-person examination, and grade their ability in a methodical fashion is not easy. But that's, of course, what we would aim for.
Thank you, sir. Srinivas, would you change your diet plan and your protein intake in patients who are already having a CKD or somebody who comes with an AKI and never go up to 1 or 1.2?
So Navina, I think just as you do a lot of baseline assessments for patients who come into the ICU, we need to make a very objective baseline muscle mass assessment of every sick patient who comes into the ICU, with or without AKI. And the simplest thing we can do is by a sonographic assessment of the quadriceps thickness and the latissimus dorsi thickness. This is a validated index for sarcopenia developed in ICU, and you will be surprised to know that this kind of loss of muscle mass sets in to critically ill patients as early as 48 hours after ICU admission. And this is independent of the severity score of the illness. So once you assess it, I think the loss of muscle prevention of loss of muscle mass is going to be, or probably should be, a quality marker and a metric of quality of nutrition being supplied in the ICU. So all the scores which are available is one aspect, but objective assessment which can be measured, captured, and reproduced is going to be the way to do it. There are ventilators currently available, especially the Hamilton ventilators, which are going to give you the respiratory quotient, the resting energy expenditure, but that's not going to tell you how much of muscle mass, how much of protein balance you are able to, although the nitrogen balance can be calculated, how much protein balance you are able to achieve in your patient, it cannot be quantified in numbers. So this is one of the extended uses of point of care ultrasound where nutritional assessment can happen. So I would probably go in that direction for the situation or the type of patients you are talking about. And this is also applicable for oncology patients.
Once when we see burns patients, like in the recovery phase, we almost used to target 2 grams per kg per day of protein. So that's about the higher requirement of patients. But is other conditions about the oncology where we target a low peak?
Your voice is gone now. I couldn't hear you.
Can you hear me, sir?
Yeah, now
Yes.
I can.
Are there any conditions where we want to target a lower protein rather than the higher protein? Like the oncological patients that we're talking about?
No. I don't think lower protein. I don't know whether Ghanshyam has any other different view.
Less than 1 gram protein, the least you need to give is at least 0.8 to 1 grams. Okay. Now, the only condition, even in patients with fulminant hepatic failure, even in those patients, or even in patients with acute kidney injury, you generally don't go below 0.8 to 1 gram. So there is, I can't recollect any condition where you go below that. Now, the second thing is, when you're talking about patients with acute kidney injury or patients with CKD, one important parameter which determines the amount of protein that you give is whether they are on dialysis or not. If they are on RRT, if they are on dialysis support, then there is no need to restrict the protein. You need to give what you would normally give, 1.2 grams per kg per day, because one, they are catabolic. Second thing is, they also lose a significant amount of proteins during the dialysis. So you need to replace that. So key determinant would be whether they are on dialysis or not. The question with respect to what should be the outcome parameters, as Srinivas said, I think one of the key aspects is to see what is happening with ICU acquired weakness. Now, mortality, there are multiple factors which influence mortality, but of late we have realized the importance of the quality of life post-discharge, and we know that almost 70 to 75% of the patients who are admitted to the intensive care unit develop ICU acquired weakness or sarcopenia. So, this was one of my thesis topics for one of my DNB students, where we looked at the quadriceps femoris muscle mass on day 1, day 3, day 7, and day 9, and there was a consistent and significant reduction in the muscle mass at day 9, especially in those subset of patients where the protein delivery was less. So that is something which is very easily available, can be repeated at the bedside, and it's a very well validated score. The use of ultrasound to look at the rectus femoris is something which can be easily done as a method of assessing whether your nutritional delivery as well as nutritional uptake is optimal or not.
Thank you, sir. Dr. Priyanka, you want to conclude anything after all the discussion?
To give the standard protein to the critically ill patients.
Okay, thank you.
To
So your
use
conclusion,
focus
sir,
group.
Joe, sir?
This study augments the previously held belief that excess protein may not be helpful. Indeed, it may be harmful. So across the board, in critically ill patients who are on ventilation for, say, 3 days or more, a protein dose of 1 to 1.2 grams per kilogram per day should be adequate. So that's the bottom line to me.
I just wanted to ask one more thing about the amino acid administration. Would you recommend amino acids?
I don't think there is any specific requirement for the use of amino acids. Proteins, as we administer with the enteral feeds, enteral nutrition, should be adequate. I haven't actually come across any study that has specifically looked at specific amino acids in ICU patients.
So there was one trial, Nephro RCT, which looked at the amino acid infusions, during, I think, dialysis period, during dialysis period. But again, that study did not show any major benefit with the infusion of amino acids.
Okay.
Your conclusion, sir, Srinivasa?
One more addition to the less is more list in critical. That's all I can say.
Thank you, sir. Ghanshyam, sir, one final question. Will this change your practice?
Not really, Navina, because see, we, as I've said, the way we dose our proteins is in a much more graded fashion. I would never give a higher dose of proteins in the first at least 48 to 72 hours. We start at 0.8 to 1, then we go up to 1.3. And yes, when the patient is being shifted out of the ICU, when the patient is able to undertake rehabilitation, when the patient is able to be mobilized, and when I know the acute illness is over, that's when we go up to 1.5 to 1.7, that is the current practice that we are doing. Just want to add a point about, does the amino acids make a difference? It's very important to know what quality of protein you are giving, because the amount of leucine that is there in your protein is very important, because leucine gets converted into HMB, which is a potent stimulator of your mTOR pathway, which is your anabolic protein synthesis pathway. So yes, you need to look at also not only the amount of protein, but also the quality of protein. So this particular study will not change the way I am going to feed my patients. But for me, I think the timing of your nutritional delivery, both with respect to calories and proteins, will make an impact on the outcome.
Thank you. Thank you, sir.
Shiva, your thoughts?
Nothing, sir. I mean, I wouldn't actually change my practice, what I'm currently practicing. It's the same thing. And as everybody has viewed the same thing, that we wouldn't go ahead with high proteins, use the standard proteins for the better outcomes along with rehabilitation. I think that is much more which has to be emphasized, especially when a patient is on mechanical ventilator. We should try to see if we can rehabilitate the patient by doing some sort of a mobility. In fact, I think in the Western world, the mobility nurses are actually, involved in the patient care. In fact, I was watching some of these videos, how they are actually taking ventilated patients on a walk. So which would actually improve their muscle power in a better way rather than giving just additional proteins, which can harm the patient. And regarding your question, sir, I have a query. I think some of the commercial preparations are coming with HMB, high concentration HMB. What do you suggest, sir? I mean, because they say that probably their outcomes would be much better.
See, hydroxymethyl butyrate, if you look at the protein synthesis pathway, HMB is something which stimulates your mTOR, which is needed for your protein synthesis. And in critically ill patients, there could be a potential deficiency of this. And not only in ICU patients, but in patients, elderly patients who are sarcopenic. HMB in the dose of at least 3 grams per day is now recommended to prevent protein breakdown. So I think this is one among the various interventions for anabolic nutrition. One of the methods that has been tried out is the use of HMB. I think it's going to be we should be giving it at least no harm. But as I said, it is just not just about the nutrition, but the other aspects where you are combining it with an active rehabilitation program. So HMB is one of them. That should be included in not only your ICU patient, but also in your patients who are elderly, who generally have this muscle loss.
Yes, sir.
Okay.
Hopefully we can do some sort of a research on this, sir. Maybe I think maybe Hyderabad LCCM can go ahead with some sort of a multicentric trial on HMB. I think probably there's no evidence actually. I have actually gone through a lot of things, but no evidence per se on HMB, sir.
Okay, thank you, sir. So from this month on, we have a small, yes, Dr. Priyanka.
Thank you so much for the opportunity.
You're welcome. So from this month, I think we have a small discussion on the statistical snippets. I think for this month, I think I've chosen to speak about the topic that we usually come across in statistics, the number needed to treat. To define itself, the number of patients and a clinician should treat in order to prevent one adverse outcome or to cause a benefit for any patient is the number needed to treat. NNT can be for benefit, NNTB or NNTH. So it's usually the number of patients that need to be treated with an intervention in order to have an impact. It can be a benefit or a harm on one patient. So it applies in equal measure to both benefit and harm, and the terms used are NNTB, NNTH, or directly NNB or NNH. This concept is essentially one based on noting the frequency of occurrence of an outcome measured as a cumulative incidence of that outcome per number of patients followed up over given a period of time. The period of time is also important. This will result in a proportion of patients with outcome over a period of time. Then we write it as a percentage. Simply put, it's nothing but the reciprocal of the absolute risk reduction. So for an example, we'll talk about this where there was an intervention of zoledronic acid in patients to reduce, and the outcome that was measured was the reduction in the number of fractures. So in placebo, the number of men with fractures were around 28 out of 546 patients. And out of 574 patients, and those with the intervention of zoledronic acid, only 9 patients. So when we calculate the absolute risk in these patients, In the placebo group, it is about 0.04, which was a 4.87%. We'll take it as a 5%. And in the second group with the zoledronic acid, it is about 1.68% or 2%. So when we calculate the risk difference, it is about 3%, which is 0.03. Now, how do we calculate the NNTB? It's 1 by 0.03, which means 33 patients. So in this NNTB, that means to see an advantage or a reduction in the fracture for one patient, we need to treat at least 33 patients. This is about the NNTB. And when it comes to harm, we'll see the absolute risk in patients receiving prasugrel pre-angiography followed by 30 in the in the event of PCI. And the other arm where placebo, where pre-angiography followed by 60 mg prasugrel in the event of PCI. So here the absolute risk of bleeding in the arm of the prasugrel was about 2.6%, and that of the intervention group was 1.4%. So as we calculate the absolute risk reduction, the absolute risk reduction is 1.2%. Now the NNTH will become 1 by 0.012, which is about 83 patients. So the NNTH of this would be, if you treat 83 patients, you can see one patient with a risk of bleeding. So in this, what is important is when we have a NNTB, the lower the number for a better outcome, it would be a better thing. But for a NNTH, the general rule of thumb would be the higher the number of patients that you treat for one adverse outcome would be recommended. So if NNTB increases, fewer and fewer patients would be helped. As a general rule of thumb, lower the NNTB, the better is the treatment. The next concept, we also have number needed to screen, which was actually developed in 1998 and is defined as a number of people that are needed to be screened to prevent one death or any other event or in one life year gained. It is conceptually similar to the NNTB and NNTH, but its calculation is slightly different. If we take the mortality in the patients with breast cancer before screening mammography and after screening in the women aged 40 years, the death rate without screening would be 3%.
Navina, we lost you.
Yes, sir. Can you hear me?
Yeah.
Thus, the death rate without screening would be 3%. But if we assume that a screening technique has been developed where the death rate actually reduces the mortality by 90%, that means the deaths will be 3 per 1,000 women screened. So because of this intervention X, there's a 90% effectiveness. 27 lives per 1,000 women screened are saved compared to the arm where there was no screening done. Since 27 deaths were prevented for 1,000 women, for one death to be prevented, 37 women would be needed to be screened. That is the NNTS. This is also similar to NNTH, where you NNTB, where you want lesser number of people to be screened to have a more more outcome. But if there was but if intervention Y were to be produced, only 10% of reduction in the mortality, that is only 3 lives would be 3 lives per 1,000 women would be saved. To save 1 life, here you need 333 people to be screened. So logically, the lower the NNS, the more useful the screening is the screening test. So when we have multiple screening tests for any particular disease, so we look at the numbers needed to be screened and then take the call which one would be more effective. So another is the likelihood likelihood to be helped or harmed ratio. The ratio, it's the ratio between the NNTH to NNTB. The value of LHH should be greater than 1. And the further away from 1 that the value is, it's the greater likelihood to the intervention that the intervention produces more benefit than harm. Then there are different challenges associated with the use of NNT. Any comparison of NNTs must be made with a clear understanding of the baseline risks that are involved. Similar to other measures, in statistics, the number needed to treat should be always accompanied by a confidence interval. It's important to state the comparator that is in both the groups. Simply stating that drug X has a particular number of NNT doesn't make any sense unless we have another comparator group where we have an intervention of Y. Stating the time frame is also very important in the NNT. And NNT has an infinite value when the absolute risk reduction is 0 or which is close to 0. And the NNT is dependent on the choice of the binary outcome. And it may not translate into the same NNT value when the intervention is actually used in the real world setting. To conclude, NNT offers a clinician's yardstick for measurements as it helps compare benefits and harms by converting them into a single number. It helps clinicians to make an informed choice when more than one intervention is available. The explanation and elaboration document of the CONSART guidelines suggests that the NNTB and NNTH can be presented as metrics of binary data from the RCTs. Clinicians should learn how to derive and use NNT results of the RCTs as a reciprocal of the absolute risk reduction. However, since benefits and risks are two sides of the same coin, each intervention in a RCT would have both NNTB and NNTH, and both need to be considered in tandem so as to make careful, individualized, policy-centric patient decisions. Thank you.
Thank you, Navina.
Do you want to add anything?
No, I just want to emphasize the fact that infatuation.
Srinivas, you're on mute.
Thank you. No, I'm speaking. Can you hear me now?
Yes,
Yeah.
sir.
So our infatuation with the p-value is what I want to speak about. So it is not a value of clinical significance. It is a value of statistical significance. The fact we have to remember is everything that is statistically significant need not be clinically significant. For example, if you do an antihypertensive drug therapy with two different drugs, one drug may reduce the systolic blood pressure by 1 millimeter of mercury, which is statistically significant. But that statistical significance may not translate into clinical significance. The clinical significance is determined by the absolute and the relative risk reduction, or its reciprocal, the number needed to treat and the number needed to harm. So, if there is an intervention where the NNH and the NNT are close to each other, it's not going to be an effective intervention in the long term. The bigger the difference, higher the NNT, again, the intervention is not going to be beneficial. So lower the NNT, higher the NNH will be the most ideal intervention. This is what I want to emphasize. Joseph, I don't know whether you agree with me.
I agree with that, Srinivas, certainly. And also, we don't have any standards for what is an ideal number needed to treat that would make an intervention useful. That's another question that needs to be looked at, really.
Yeah.
How many? 10 patients, 20 patients? We don't know.
Yeah, we don't know. Yeah. Thank you very much.
Thank you, sir. Thank you, Priyanka. Thank you, Dr. Shiva, sir. Thank you, Joe, sir, Ghansham, sir, and Srinivas, sir. We'll see you next month. Do subscribe to our YouTube channel for the latest updates.
Thank you. Thanks a
Thank you.
lot.
Have a good day.
Thank you, sir.
Thank
Good
you. Thank you,
weekend
Shiva.
also.
Thank you, Priyanka. Thank you, Navina.
Thank you, sir. Thank you so much, sir.